Welcome back to Health Data Ethics. I'm your host, Jenny Owens, and today we're going to go deep on guidance that shapes most of the healthcare AI landscape in the US today. That's FDA's Clinical Decision Support Software Guidance, finalized in 2022, just updated January 6th of just this year. Even if you've never read this guidance cover to cover, and let's be honest, most people are not mega dorks like me and have not read it, but this guidance impacts the way AI tools for diagnosis, treatment, and clinical workflows are built, marketed, and regulated. And today we're going to break it down in really practical tools. So what makes a clinical decision support tool regulated by the FDA or not? What role does human in the loop play in that distinction? And what do product teams, compliance people, and policy advisors, what should they be doing right now to stay on the right side of the regulatory line? But also, what do organizations as a whole need to consider as they govern their entire AI program? Not just on a case-by-case or product-by-product basis, but what do you need to think about as you're governing AI for an entire organization? We're also going to pull in thinking from a related FDA guidance, the Good Machine Learning Practice, which introduced the loop framework. That's human in the loop, human on the loop, and human out of the loop. So let's jump in. First, I want to talk about what FDA Clinical Decision Support Software Guidance actually says. So it lays out when clinical software is not considered a medical device. There are 4 criteria that must all be met for your software to avoid FDA regulation as a medical device. So we're going to dive right in. Criterion number 1. Your device is not intended to acquire, process, or analyze a medical image or signal. This is a negative criteria. It is a definition of what your software or your AI tool is not. FDA is very clear. If your tool analyzes a medical image, signal, or pattern, you are out of scope for this exemption. This applies even if you're doing something kind of subtle, like maybe you're filtering out noise, maybe you're detecting abnormalities. So a real world example, because I find it much easier to grapple with these things when I've got an example in my hands. If you're analyzing a photo of a mole to determine whether it's malignant or benign, that is acquiring and analyzing a medical image, which means that you have failed criterion 1. Criterion 2, your software or your tool is intended for displaying, analyzing, or printing medical information about a patient. Okay, this is cool. Clinical decision support tools are allowed to analyze patient data, but it must be medical information that is already captured, like labs or vital signs or history from the EHR. And this criteria is a positive criteria, right? This is a definition of what your software does. So you're not pulling data from a sensor or a signal directly, but you're using existing information to generate insights. So back to our photo analysis tool that we just talked about, taking a picture of a mole, determining whether it is benign or malignant. This also fails criterion 2 because it's not displaying pre-existing medical information. It is actually acquiring new information. Criterion number 3, your tool is intended to support or provide recommendations to a healthcare professional about prevention, diagnosis, or treatment. This is another positive criterion. You're allowed to provide recommendations, but you're not allowed to make the decision. Your tool can suggest a treatment pathway, it can flag a risk, or it can offer differential diagnoses and decision-making about how you might want to proceed, but it cannot do those things autonomously, and it cannot do them in a way that implies it's the decision maker. So the tool needs to help your doctor or your nurse or your billing and coding specialist think. It's not going to think for them. So back to our dermatology photo analysis example, that's also going to fail criterion 3 because it's providing a specific diagnostic output. It's malignant or it's benign. It's not recommending a differential diagnosis approach. This leads us to our most nuanced and heavily scrutinized criterion 4, which says that the software must enable the healthcare provider to independently review the basis for the recommendation so that it's not the intent that such recommendations be primarily relied on. So specifically, if the clinician can't verify what the thing is for, what data went in, how the system got to its output, and how it was validated, then that is a regulated device. I want to dig into this a little bit more because there's really 4 critical questions here. The end user know what the software is for? What's its intended purpose? And do they know it's not for time-sensitive tasks? FDA takes the time to call out really clearly in their guidance that using clinical decision support software under time pressures can increase the risk of automation bias or the tendency of humans to over-rely on suggestions from an automated system. Question number 2, can the user identify what data was used by the tool? It should be clear to the user in plain language about what information is required to use the tool, how do you get it, why it's relevant, and what are the quality requirements. So how do I know if my tool, for example, is grabbing like a blood pressure? What's the quality requirement on that? Can the end user understand the algorithm or the approach that's used to arrive at that recommendation? This is really intended to cut down on black box tools, right? We want our things to be clear, we want them to be explainable to the end users, and also to people who are impacted by their use. We want to make sure that end users have gut check whether they agree with the approach. This information also needs to be in plain language, and this is not a trivial undertaking. Just imagine you're trying to explain how our dermatology assessment tool works to a friend or a family member who's not in healthcare or tech. How would you reassure them that it's going to work equally well on dark and light skin? How would you reassure them that it works equally well on skin that has lots of body hair versus skin that does not? What about tattoos? What about bruises? I mean, there's a lot of factors to consider here, and all of this needs to be able to be communicated in plain language. Question number 4. Is it clear that the output of the tool is a recommendation? And does it provide sufficient relevant information for the provider to truly independently review the recommendation and apply their judgment? And if the answer to any of these is no, then once again, you are out of bounds for that clinical decision support exemption. You are into software as a medical device territory. FDA has this one hilariously dry, single sentence that I love. In some cases, developers may need to perform usability testing to evaluate if their implementation meets criterion 4. In other words, this is where communication, training, support, and monitoring really come into play. This is the domain of the deploying organization, not the developer, but the deploying organization. It is entirely possible to implement a software or an AI tool that was developed in alignment with these criteria in ways that break these criteria and shift the use of the tool into FDA-regulated territory. It's that combination of tool, implementation, and use that really matters. This design in Criterion 4, where the tool is required to transparently deliver information and recommendations to an end user who retains that decision-making power, this design is often called human in the loop. I want to deviate for a second and talk about the other ways that humans and loops interact. In 2021, FDA, Health Canada, and the UK Medicines and Healthcare Products Regulatory Agency released joint guidance on good machine learning practice. And in it, they introduced the loop model. There's 3 different ways that humans and loops can interact. Number 1 is human in the loop. So your AI tool or your machine learning tool recommends, and the human makes the final decision. You can also have human on the loop. Your AI is acting autonomously, but a human can monitor or override if needed. And then we have human out of the loop, where the AI is acting truly autonomously without human oversight. So pulling back into our current discussion of clinical decision support systems, this CDS exemption is only going to apply to human in the loop systems, where the clinician is actively reviewing and deciding. If your AI is human on the loop or human out of the loop, where that software is acting either without clinician input or it's primarily relied upon for decision making, congrats, you're in FDA-regulated software as a medical device territory. That includes if you've deployed human in the loop software in ways that move it to human on the loop. In general, this is really good guidance from FDA. This helps clarify what FDA's goals are for regulation. They want tools that healthcare providers can use, audit, understand, and choose the ways in which they use and act on those recommendations. They don't want tools that function as black box, autonomous diagnosis makers, treatment selectors, etc. Where healthcare systems need to pick up the baton and govern is when we start thinking about, okay, this is great for a one-off product, right? This product, we can say, meets these criteria. But working in a hospital system, we don't use just one product. We use a bunch. We are managing an entire software and AI portfolio. It is fine to be a human in the loop on one product for one workflow. What does that mean if you're one human who's in the loop on 3 workflows? What about 10 workflows? What about 30 workflows? Does the design of these tools and that plain language description of the data, the algorithm, the approach, the additional information, does that take into account the cognitive capacity of the person receiving the information if this tool is one of many, all pulling on those judgment and decision-making skills? And the very basic example that I keep thinking about is not actually even patient care related. In the past, I've managed people and I've used HR software to do so. I found the process really frustrating and confusing because the software was new to me and I wasn't sure the ways I was supposed to be navigating, what's important, what's not. And my HR rep was assisting me, and she shared that the expectation was that managers were spending an hour a day in that software, building familiarity and expertise, spending maybe an hour every other week. That was not nearly enough to build fluency and retain information. So when I'm thinking about our training, our communication, and our expectations for our caregivers, we need to make sure that we're truing up the developer's expectations about how end users are interacting with the tool, with the reality of how that tool is going to be used, and also the reality of what it means to staff a hospital. You know, clinicians have service and then go off of service. Nurses may rotate shifts, they may rotate floors, they may have patients who either, have or don't have these tools on. How do we make sure that people get the training and the support that they need, and factor in that very few end users are going to have the luxury of undivided attention? This, I think, is going to emerge as a real need for AI governance, not just governing our individual projects or our individual use cases, but governing our portfolio and our user experience as a whole. Thank you for joining me on this episode of Health Data Ethics as we dove into FDA guidance on clinical decision support software and software as a medical device. I'm your host, Jenny Owens. You can find me on LinkedIn or on YouTube. I'm at the Health Data Ethics Podcast, and I will see you next week.